So welcome to this Fox Fellows event. The Fox Fellows, I just want to introduce it to anyone that's not familiar. The Fox Fellows is an international exchange program set up by Joseph C. Fox in 1998 to promote peace and prosperity between nations. Emma Goldberg was a Fox Fellow in 2016. She was what we call an outgoing fellow who was studying at Yale and spent a year at Cambridge working on a comparative study of gender-based conflict around the world. At the Fox Fellowship, one of the ways we pursue our mission is to facilitate the research and career development of future global leaders who are addressing the most pressing global problems of the day. As an award-winning journalist covering health and gender issues, Emma truly exemplifies our model of citizen, scholar, global leader. So we're thrilled to have this opportunity to showcase her work. We also have three exceptional panelists to comment on Emma's work and the problems faced by healthcare professionals over the course of the pandemic. Jessica Gold is an assistant professor of psychiatry at Washington University in St. Louis's School of Medicine. You can find her work in Time, Newsweek, Forbes, InStyle magazine, and many others. Lynn Fielen, and please correct me if I'm getting that wrong, is a professor of medicine at Yale and the Child Study Center. Her incredibly innovative research uses video games to increase positive health practices among youth and young adults. And Renee Almeling is an associate professor of sociology at Yale and the author of a recent book you might also want to check out, Gynecology, the Missing Science of Men's Reproductive Health, and Sex Cells, the Medical Market for Eggs and Sperms. So without further ado, I'm going to turn the reins over to Emma so that we can get started on this fascinating conversation.
Thank you so much, Emily. And I want to thank Emily and Julia for having the idea for this event. I think one of my goals with putting out the book was to use it as an opportunity to talk with people across all different areas of medicine and medical research to kind of continue the conversations that I started with the doctors who are in the book and keep pushing the discussion and exposing new areas that we should all be writing and thinking and researching on. And the Fox Fellowship is such a perfect venue for that because there are so many people who are part of this program who are doing fascinating research that's also very impact focused and really, you know, creating change in their communities, both at Yale and around the globe. And also thank you so much for Isabel for putting this together and making this all run so smoothly. And I'm thrilled to have these particular panelists here because I think they all speak to different aspects of medicine that kind of came to the fore during the pandemic that are going to be issues that we need to keep delving into over the coming year, that even as our communities are reopening, whether it's Jesse's focus on mental health, Lynn's experiences on the front lines, Renee's work on equity in medicine, these are all issues that I think we're going to need to delve into even further, even as we're starting to see life looking a little more normal. So I actually wanted to start out, if it's okay, with you, Lynn, because I interviewed you for the book Life on the Line, and you were, when we spoke, it was last summer, and you had just been coming out of weeks and weeks of treating COVID patients at Yale New Haven and really helping mobilize the hospital's response. And you shared so much about the way that the pandemic changed the kind of normative modes of giving patients care, the ways teams in the hospital work together. So I wanted to start out by asking, you were on the front lines, what are some of the ways that the pandemic changed the way you approached caregiving and your kind of the relationships you had with patients in the hospital?
Yeah, so thanks, Emma, and thanks for including me in this panel. I think the goal of including different voices really makes this an incredibly rich discussion, which I think is also what you did with your book, is included different voices, which was absolutely critical. So, I am a practicing physician in the hospital. I also run one of the inpatient services at Yale New Haven Hospital. So my experience was kind of twofold. One was from a system standpoint, where, as you mentioned, we had to just completely turn everything upside down and re-establish an entirely new system to deal with the pandemic, which really hit us starting March 13th of 2020. And that included developing a whole new system of teams, a whole new intensive care unit system, bringing in community doctors. We had volunteers, upwards of 350 volunteers, including the dean of the medical school who signed up first. to come and work on the wards in whatever capacity we could use that. So those were, you know, very seasoned community dermatologists who came and acted as interns on the wards. So it really was an all hands on deck. And if we're looking for silver linings in this pandemic, I have to say, and I think I would be reflecting on a number of my colleagues who just said that it really brought about this team effort. You know, it really brought about sort of the best in people to come together to help deal with this when we had this huge influx, not only in Connecticut, but in neighboring states, of patients coming in critically ill with COVID. So that was sort of the system shift that I was involved with, what felt really like 24/7 in terms of creating a new system within our hospital of how to take care of these patients on a more sort of personal level, being on the wards. And when I was on the wards, I was working in an entirely COVID positive unit. And that was an entirely different experience. One, because my relationships with patients changed so dramatically. You know, we're used to caring for patients while we provide treatment, and all of a sudden the caring part was in some ways really pulled back because we had, you know, head to toe garb. We had to keep distance. We couldn't touch patients and examine them in the way that we were used to, or sit on their bedside to talk with them. There was a whole new element, honestly, of fear in being a healthcare provider, just in what we've seen, you know, with tuberculosis or early in the HIV/AIDS epidemic. So there was that feature. And then there was also the feature of, you know, working with house staff, with residents, with, you know, the folks that you spoke with in your book. And honestly, we were blind leading the blind. You know, I mean, it was an amazing, rapid influx of, you know, intellect and knowledge that we had to sort of create on the fly. But I really saw my residents and even my medical students as my peers. You know, we would both look at each other and say, well, what do you think we should do? And it was completely uncharted territory. So while that was in some ways very rewarding, that we were really learning alongside our trainees, it was also, you know, as an attending and somebody who's been doing this for years, it was obviously really challenging to feel like I didn't have the information or the experience in treating this virus or taking care of these patients, that I could really lead my team in a way that felt like I was fully effective. So that just gives you a few examples of both kind of a systems and then also more of my experience as a healthcare provider.
Yeah, that's so fascinating. And I think one of the really interesting issues you raised is the simultaneous shift of some positive norms, like that spirit of collaboration, a little bit of like the shaking of the hierarchy in medicine, in that really seasoned doctors like yourself were working alongside much more junior people, in some cases people who were really just starting out their careers, and everyone learning alongside one another in real time about this really novel disease. And at the same time, the negative of the new sort of barriers between doctors and patients, not being able to use physical touch in the same way, and, you know, having to rely a lot more on body language because you couldn't always see people's faces behind all the PPE. So if you don't mind, Lynn, I have one more question for you, which is, how do we think about, you know, how to save some of the more positive shifts that came about during the pandemic while shifting back to some of the older aspects of medicine that were perhaps better for patients or better for doctors than what was happening during the height of the crisis? For example, you know, being able to rely more on those like physical and close emotional relationships with patients. So I'm curious, kind of, as norms start to shift again, and as case counts continue declining, how do we kind of allow for some of the positive shifts and also still retain some of the things that happened during the pandemic that are perhaps worth salvaging within medicine?
Yeah, so I mean, that's a great question. And I think there are challenges in both of those things. I think, you know, one thing we've certainly seen with the pandemic is this explosion of telehealth and telemedicine, right? Which in some ways is a huge positive, because what allows access to a lot of people who may otherwise might not walk into an office or, you know, interact with the healthcare system. But then on the flip side, it takes out, you know, off the table the, in-person interaction that providers and patients both really benefit from. So I think we have to be really intentional. I think we have to, I think in terms of the system, it really shook things up. And I think we learned that, one, being highly collaborative, and sort of breaking down the silos and all the sort of territorial barriers can be really positive, that we're all in this together. And we're in this together to really, the end point is to take good care of patients. So that became so critical in terms of learning from that. So I would say, as much as we can continue, with that sense of collaboration, that sense of that we are one team. I mean, it sounds a little hokey, but we're one team in this together, and we have created systems that work, and there's no point in reverting back to systems that are antiquated and don't work. On the flip side, my hope is that that we also start feeling reassured that things are under better control. I mean, as of this morning, I think we had 4 patients with COVID in our hospital, none in the ICU, so that is hugely reassuring. Then we can start feeling comfortable about having more, closer contact with patients, because that is so critical. I think the other thing, and Jesse can speak to this, way better than I can, is I think the other thing that we really learned is that this pandemic amplified the enormous strains and impact on mental health for healthcare providers. And we needed to implement some systems to address that. That is, once the pandemic goes, that doesn't mean that all of that stress and, impact of the pandemic goes away. It doesn't. But we also know that it's always been there. The pandemic just amplified it. So I think being very cognizant of taking care of the caretaker is absolutely fundamental, not only for the immediate mental health of everybody, but also for the longevity, right? Burnout is a real thing, and it's not going to get better unless we take care of people now.
Thank you so much. And that is a perfect segue into the work, Jesse, that you've been doing throughout the pandemic. And I think what was fascinating, something I've heard from the times we've spoken, is that you were on a front line that looked very different, but it was extremely taxing in another way. You were providing constant mental health support to people, and also reorganizing the way that your own system provided mental health support to providers across the medical system. So I was wondering if you could just start out by talking a little bit about how the pandemic changed your day-to-day work and the way you interacted with your own patients.
Yeah, thanks for asking. I appreciate the setup, Lynn. Way to just like alley-oop into mental health over here. But, I think mental health is interesting because I think we don't honestly think of ourselves as frontline providers. And I think it's one of the things that's really hard about being a mental health provider. For me, I went to medical school. I'm a psychiatrist. I trained in medicine. So I see my friends, a lot of my friends are on the front lines directly exposed to getting COVID. They could be at risk to get COVID. My sister's internal medicine doctor and had to, go work COVID units. So I'm seeing all these people that I know like directly exposed to COVID, and my day-to-day work is behind a computer. And so for me, I didn't feel like a frontline provider. I felt like somebody who's behind a computer all day. And so it was very hard for me to conceptualize that I was doing something that was the same or at any risk of burnout or at any risk of something that could be equivalent in any capacity. I see healthcare workers and faculty and staff as like a primary population of what I do. And that only grew over COVID. In March, I'm in St. Louis, so it wasn't like the first hotspot, but when things started happening on the coasts, we really quickly started going like, how do we prepare our hospital for what's coming? And for us, I was like, well, I don't want to be working in an ICU. That's not the best use of my talents, and it's not the best use of psychiatry. We really should be helping the mental health in some capacity. And I've always been interested in mental health of healthcare workers since forever. And so I was like, this is going to be a problem and we need to be prepared for this. And so we started calling the coast and seeing like what they were doing and trying to implement that here at the best of our capacity. We set up a hotline we tried to increase appointments. We tried to hire more staff if we could, and really tried to be ready for that. And that also meant I increased appointments. And so we were like completely prepared as best as we could. And, you know, I just started doing more appointments, started seeing more healthcare workers. And so I was seeing a lot of healthcare workers by, you know, mid-pandemic. That was a lot of what I was doing. I see college students too, but, you know, a lot of family members of healthcare workers at the same time, which is a whole different aspect of this. And, you know, I think I was just seeing a lot of people, and I would get really tired after work and just be like, why am I so tired? This is so weird. It makes no sense. And really, I was burnt out and had no realization that that was at all related to the work I was doing, because I had a hard time like associating being behind a computer at all with being at all related to the work I was doing. But I was hearing really hard stuff, and I just assumed that I was fine, because that's my job, is to hear hard stuff and hold hard stuff and help people as much as I can, and, you know, just do that and be prepared to help people, right? And so I think as mental health providers, it takes a long time sometimes to register that those things are affecting us. But I think that's been happening for a lot of people that I know that do what we do, which is like kind of this delayed reaction of like, oh no, we actually can get burnt out, and there's only so many of us, and actually the system's quite broken, and there's only so much we can do. And like, this is going to be a really big thing for not just healthcare workers, for a lot of people mental health wise, and we don't have enough of us, and we have to preserve us too. And how do we do that? So I think it's been an interesting sort of balance of like, I need to do this, I have to do this. There's only so many people who are quote unquote experts in mental health of healthcare workers, but like, you have to preserve yourself at the same time, and sort of balancing those two things. But yeah, I mean, it's been an interesting kind of experiment at the same time of sort of like trying to be there for everyone as best as I could, but also trying to preserve myself and learn from that at the same time.
Yeah, that, I mean, I just always find it so powerful when you share those experiences, because I do think you're right. Like that, those labels of frontline provider in the early weeks, like people didn't always understand how many people that applied to, and how many people were on a front line of some kind, and getting more and more burnt out. And so I'd like to ask you a question too that I posed to Lynn in a different way, which is, of all the kind of norms in your work that shifted during the pandemic, are there some changes that you think should stick, or kind of, you know, shifts that came about that we might want to retain even as we're shifting more and more back into reopenings and more in-person gatherings and that sort of normalcy?
Yeah, I mean, so the biggest thing for me is that we talk about feelings in healthcare. I mean, we, you know, existed in this space where, you know, physicians had among the highest suicide rates of any profession. We had, you know, depression rates where we entered medical school with equivalent depression rates of age matched peers. We leave with much worse, like in the high 26%. We have use of substances, like especially prescribed substances, higher than age matched peers, right? We're not doing well. Our burnout rates are like 50%. That's not a good percentage either, right? We have really bad mental health. Then COVID comes along, we get even worse mental health. All it's going to do is compound it. The data that we already have doesn't look good. Like the depression rates out of New York in those studies are like 40%. The PTSD kind of measurements of like acute stress are like 30%. Those are not good numbers. If you add that on top of what we already have, we're not going to see that being like an awesome situation for healthcare workers, right? And that's just measuring like physicians and nurses, right? Not the people who are directly really on the front line, most likely to be exposed to COVID, most likely to be at risk to get COVID or die from COVID or see a coworker die from COVID and are the voiceless, really, right? And so I think that what we're missing, and like what we've missed in healthcare for a long time, is like a population that talks about this, right? We've always known it's a problem, but we've never talked about it as a problem. It's always been sort of this like well-kept secret in medicine, where medicine was like, oh yeah, like we know this is a thing, and like we'll do some kind of like lip service to it, and like, oh, our organizations say we need to talk about it, so we'll do a lecture, or we'll offer yoga, or we'll like do whatever the bare minimum we need to do to like have a checkbox and maybe like offer some services and get through with it. But during the pandemic, like we just have had enough, right? Like healthcare workers have like cried on TV and vocalized how they felt in social media and like really openly talked about how this has affected them in like journalism. Like you can read what you've written, you can read what like some people, like there's a great New Yorker piece by another Yale alumni who was like in my class, Drew Kular, that someone talked about having PTSD very, very openly and greatly in the New Yorker. And I think like that sort of stuff would not have happened like before COVID. Like it's just was not something we talked about in medicine. It's not something that was accepted. It was not something that was okay. But it's sort of like we hit this point that we're just like, what else? Like we can't do, like if we don't have, like if we can't talk about it now, like when can we talk about it? And I'm sort of hoping that like we move forward and we say like, this isn't something that's going like back in a closet, and that we acknowledge that like this is actually what medicine is like often and not just during a pandemic, and that we need to like keep talking about it and keep it as the culture where it's not just something we don't talk about, but it's something we openly discuss and that we try to fix because we openly discuss it, and that we try to like make sustainable changes and not just these like band-aid changes, and that like just because like, you know, hospital systems like mine or like other hospital systems like put money into this over COVID, that's not just like COVID money, that's like money that they want to put in permanently, right? And that they realize that like you can't just say like this trauma is going to affect our mental health for a year. Like trauma, like therapy is long lasting. People are going to come up with things that require treatment years from now, right? And so I'm hoping that the things that really change are that like this lasts and the culture of it lasts, and the realization that this needs to be an investment lasts. And that's what I would like to see change, honestly, is this like integration of this into medical culture.
That is so powerful, Jessie. Thank you. And I want to encourage everyone to check out Jessie's writings on this, because she's written, as you heard in her bio, in so many different publications on just putting a spotlight on mental health within healthcare. And it's such important work, especially right now. And shifting gears a little, I wanted to pose a question to you, Renee, which is that, you know, Jessie was talking about some of the challenges around healthcare workers feeling like they can talk openly about their emotional experiences on the front line. And something I learned in speaking with some of the residents who are in my book are some of the ways in which stereotypes, both gendered and racial and others, hold people back from both being able to fully express themselves in the workplace, from being able to fully show up with all of their emotions in the medical workplace. And there was a sense, particularly from some of the women of color that I followed, that they had to sort of suppress all different aspects of their identity or their kind of emotions in the workplace in order to just put their heads down and kind of get through the day to day. I remember there was one woman I followed named Gabriella, who in one of her clerkships when she was in medical school, she was going around the wards with a doctor, and he introduced her to a patient as mi amigo. And she's a Hispanic woman, and she was just so taken aback because it felt so inappropriate. And in that moment, all of these thoughts were going through her head about, you know, she felt offended, she felt embarrassed, and she also felt like she had to say to herself over and over, like, just laugh it off, don't say anything, don't report him, don't at all look like you're, you know, ruffled by it, because she knew that in order to continue advancing, to get good evaluations, she didn't want to stand out as the person, particularly as a woman of color, who was, you know, ruffling feathers or speaking up. And Renee, you've done so much critical work on inequities of all kinds in healthcare, and particularly on gendered issues in the workplace. And I was wondering if you could speak a little bit to what you see as some of the greatest barriers to particularly women's advancement in medicine, and especially women of color.
Yeah, well, I think it's a great question. And that, you know, the anecdote about Gabriella is so powerful, in part because as you write about it, you know, she's not sure even if it's in her head, right? Should she even be offended about that? And so also, people questioning themselves, not only that that person was going to file an evaluation of her later that week, but she couldn't even sort of, bring herself to kind of think about like what that interaction meant. So yeah, I mean, I'll answer your question by sort of talking a little bit about what I think you do really beautifully in this book, which is to take these 6 doctors and their experiences of graduating directly into a pandemic. And I'm not going to say front lines because you do talk about battle metaphors as one of the things that we sort of have to think about when it comes to medicine. But these 6 doctors who graduate into a pandemic and the ways that their experiences, as women, as people of color, of people, people who have sort of identify as different in some way from the hegemonic standard of, white male physician, that those experiences are sort of powerfully influencing their everyday lives as these brand new doctors. But they're also deeply rooted in a long history of inequality in medicine. And I think that that's one of the things that you do so nicely in this book is that you're laser focused on these 6 people, but situating them with this broader historical context of the history of medicine becoming a profession in the 19th century and the winnowing of medical schools as the 19th century turns into the 20th. So there was, a whole array of medical educational institutions that really got winnowed down to those that primarily served whites and those that primarily served men. And so the fact that we have mostly a white male medical profession for most of the 20th century was the product of historical decisions. And so, you've got these small interludes in the book where you're talking about the residency system or historical abuses of people of color and how those are shaping people's attitudes and experiences today. So I think that's really important. And part of why medicine is unequal is because we have a deeply unequal society. So here, I'll put on my sociology hat and say, for as long as America has been a nation, we have been sort of deeply riven by gendered inequalities, racial inequalities, class-based inequalities. Today, we would add, inequalities of sexuality, nationality, ability, and those come out in the stories that you tell from these 6 doctors. And so I think that, in part because you are telling the stories of individual physicians and their experiences within this historical context, part of what happens is that a lot of the, what to do about this, a lot of the answers, to what to do about this are really focused on the physician's identities and the patient's identities and the physician-patient interaction, right? And so, in sociology, we would say that's sort of focused on an individual level and an interactional level. And I would just add to that. So I think you really spotlight those dynamics really, really powerfully with so many of these stories like Gabriella's that you started with. To that, I would also say, and to pull on Lynn's mentioning of the system, that we can't only talk about sort of individual identities and how individuals interact, but also, medical knowledge itself. Medical knowledge itself is produced by humans who have biases. And so gendered and race and classed biases are built in to which research questions biomedical researchers ask, how they derive their hypotheses, how they then provide answers to those hypotheses. So our knowledge of medicine, of the body itself is influenced by these inequalities. And the same with medical technologies, right? There's all kinds of stories that have come out from COVID, especially with the ways that racial bias is built into medical technology. So I think in terms of thinking about, what are the things that can be done and to sort of, take the pandemic, as both Lynn and Jesse said, there were pre-existing long-standing issues that were only sort of spotlighted, highlighted, underlined, bolded, et cetera, by the pandemic. But to take that, that realization, the knowledge that comes from having lived during hopefully what will be a once-in-a-lifetime pandemic, and use that going forward to think about, not only who becomes medical doctors and how their identities shape their medical practice and their interactions with patients, but the system more broadly of medical knowledge, of medical technologies, of healthcare, that all of those things, we sort of need to think anew about how inequalities have been built in order to begin addressing how to remove them and address them.
That is so fascinating, and I really love the way you look at how medical knowledge gets produced. I remember I was doing reporting for a story a couple of years ago about NIH funding and why NIH funding goes predominantly to white researchers. And the thought was for a long time that was simply because people who were applying, that there was kind of a cycle where white researchers tended to have, more, they've been promoted more, gotten more mentorship, or gotten access to kind of more opportunities, and those opportunities reproduced opportunities. And one of the interesting things that came out was that it was actually also because of the subjects that researchers were proposing to study. And Black researchers were more likely to be proposing to study kind of community-focused intervention work, and also work focused on disparities. So they actually did a study that found that applications that were less likely to get funding were more likely to have words like disparities or community or intervention. And those tended to be applications that were coming from researchers of color, whereas white researchers were more likely to have work that was kind of more clinical and less community and patient focused. And that gets to the point that you just brought up, Renee, which I think is so important, which is there's kind of this cycle of, the field is still predominantly white, and just 5% of physicians are Black, 5.8% are Hispanic. So it is still predominantly white. And then the people who get to define what medical knowledge looks like are still predominantly white. And it's a cycle that's so challenging to disrupt. And like you mentioned, is so deeply rooted in that history stemming from the early 20th century in particular. So I was wondering if you could talk a little bit about what you see as some of the most promising efforts to break those cycles, or to sort of shift, the constraints on who gets to produce medical knowledge.
Yeah, I think this is a great question, and I like that you sort of asked each of us in a different way, is to sort of think about, not only diagnosing the problem, but also thinking about how to address it. I would just, to sort of as the beginning of an answer to that question, I would echo what Jessie has said, which is, there are going to be a whole lot of Band-Aids suggested, because Band-Aids are easy and then it looks like something is being done. But I think many of the sort of systemic problems with medicine and healthcare in the United States require a much more fundamental rethinking. And I would say, the examples that you gave of NIH funding, it's not only within medicine. I mean, if you think about the amount of money that goes to medical research and fixing health problems downstream, if you compare that bucket with like the public health bucket, that I think is where it becomes most stark, right? And so in many of the stories about COVID, there was some line about the underfunded public health infrastructure, or the complete decimation over the last several decades of any sort of attention to public health. That I think is part of what we can do going forward, is to think about the disparities that we saw in terms of who became infected with COVID, who got terribly sick from COVID, and who died from COVID, are not only rooted in the virus itself, but how we organize ourselves as a society. And so because there were people who still had to go to work because they had to keep a roof over their head and food on the table and couldn't stay home and opt out, because there were unequal levels of medical care and quality of care in urban areas versus rural areas, and places where people have more money to go to the hospital versus places where people don't have money to get healthcare. So all of those inequalities that are built into our system, you could sort of take a big step back and think about the money that we spend towards medicine versus towards sort of preventive public health approaches to raise the health level of all bodies in all kinds of situations. And I think in the United States, we do a particularly bad job of that, right? And there are there are a variety of models. We could look to other countries that have a much more robust social safety net, not only in terms of healthcare, but also in terms of welfare provisions and making sure that everybody sort of has a fundamental baseline income and access to healthcare and good quality education. Those things seem like they're far removed from the health of a population, but they really aren't. And I think directing more dollars towards public health approaches of all kinds will ease the amount of money that we have to spend on medicine later.
That is really powerfully put, and I think such a fascinating kind of look at how the history of all these things flows into this moment and what's come out during the pandemic particularly. And something I wanted to ask all of you actually is that as I started to share the book with people, I've sort of gotten different versions of the question of, either is it too soon or is it necessary to already start sort of consuming the stories of what people experience, particularly at the height of the pandemic in the hospitals. And people in every field, I think, are traumatized in different ways by the last year, by the economic crisis also that followed on the pandemic, by the mental health crisis. And I've heard different versions of the question of, do we have to already start delving into the stories of what people experienced? And I remember reading a really fascinating piece about why we don't have more monuments to the 1918 Spanish flu. And one of the proposed kind of theses on that is that it was coming, the Spanish flu came also right on the heels of a war. And there was this narrative that emerged that the Spanish flu was this foreign disease that came from abroad, tried to kind of bring the US to its knees, and the US fought it back and emerged victorious, and then rushed right into the roaring 20s and everything that came after it. And there was this kind of national celebration and a desire to paint the Spanish flu as this crisis that was the other, that the US was the victor of. And it was this this kind of desire to fall into a kind of xenophobic and I think easily available for some people narrative of pointing fingers and then patting the US on the back for being able to move out of that period. And I think we've seen different versions of a temptation to do that this year too, and certainly a kind of falling back into xenophobia and into othering that's coming out of COVID. And one of my desires with the book was just to kind of start creating opportunities for people to process and talk about what people experienced without at all pretending that this is a crisis that we've emerged from, because it's ongoing in the US, it's ongoing in hospitals here, and very much in hospitals abroad, where most of the population of the globe still hasn't been able to access vaccines. So I wanted it to really be a snapshot of a period in the US, and a way for people to start processing stories and processing lessons without falling back into the othering and the pointing fingers. And so I'm curious to hear from each of you, what are some of the stories of this particular moment in the pandemic that you're hoping to continue to see the media keep spotlighting and other kind of academics and researchers to keep delving into? What are some of the stories that you feel like aren't getting enough of a spotlight right now, and that you'd like to continue seeing be part of the public conversation? I don't know if there's one of you that wants to jump in and start, or if not, I can. I don't know. I feel like, oh, Lynn.
I can start. It's a big question, so I think we could all take a piece of it and still have lots left to talk about. So I think one thing which you highlight with the experience in the early 1900s with the Spanish flu and this sort of sense of exclusivity. And I think one thing that we certainly learned from this pandemic is that we are all on the same planet, and no one was left. I mean, people were impacted in different ways, but no one was untouched. And so I think that if anything, to continue that spirit of that we're really, I mean, as I said, sort of about the team in the hospital, we are really all on, you know, the same team. We are all impacted by everybody else on this planet. And, you know, I certainly have seen those switches, and I watch the, you know, the 6:30 news, the ABC national news here. And it's always that sort of like, okay, where in the world is the pandemic really bad? And, you know, early on, I remember just watching the horrors in Italy, you know, and then it's sort of, you know, what's happening in the UK, and then obviously in Asia, and then most recently in India. And, you know, that's that feeling of a little bit of immediately feeling like, oh, you know, at least I feel safe. But then kind of recognizing, no, like nobody's safe unless everybody's safe. And so, you know, that's on a very high level of trying to maintain that sense. And this is, you know, this is true in not just infectious diseases, but so many other issues that we all deal with as humans that, you know, it's contagious and we're all impacted. So I think to be able to keep, you know, that sense of being part of a global community, and that, you know, none of our health is any good if not everybody's health is good. And that transcends obviously to healthcare systems and issues of health disparities and all that. But I think this pandemic really, because it was like tennis, right? The ball would bounce back, and now all of a sudden it's surging in the Northeast. Now it's surging in California. Now it's surging in, you know, in Italy or India. And, you know, no one was ever really truly safe until everybody was safe. So that's kind of very high level, but
I don't know. That's a good question. I'm a big fan of dialectic. So I think that you need like the happy stuff and the sad stuff and not just either, right? And I think we have like too much of both. Like I think we like really want to like find hope too much, and then we'll be like, here are all the happy stories, the pandemic's over. And then we don't talk about the fact that some people still struggle, right? And then I have patients that come and say, why is everybody okay and why am I not? And what's wrong with me, right? And then we'll have like the sad stuff, and then they'll be like, why is this so depressing all the time? This is really hard to watch. This is so triggering. I can't watch all this triggering stuff all the time. This is really hard, right? So we have a really big problem with like this like need to show one or the other. And I'd really like a little bit more balance in general. And I think it's really important for people to have the balance. And we have a problem with that. And like this desire to have like a one size fits all model for people, especially with like going back to work and like this just working for people, like it just has to be easy and it must just be fine for people to go on vacation and it must just be okay. And I think that's really hard when it's not for you. So I would like more stories where like, you know, people are human and it's not necessarily like just like super easy breezy all the time for people to do everything. I like stories of like humanity, you know, I'm biased. So anytime mental health's included in the conversation, I'm a big fan. I think that in general, like mental health is like this like side story all the time, or where people are like, there's a hidden epidemic of mental health and it's the fourth wave and all of a sudden it's coming. And I'm like, what has my clinic been doing the entire time? Like hiding? You know, and so I think that it's just like ridiculous to me. Like, I don't know what's been going on that it's hidden. So I think that it's like important to me that like mental health is more central to the conversation, because like when we talk about disparities, mental health is involved. When we talk about healthcare, mental health is involved. When we talk about climate change, mental health is involved. When we talk about like all this stuff, like, and we're never in the room. Like, in fact, like news organizations have told me mental health is like not included as a hard science sometimes. And so if you're going to tell me that, like, why did I go to medical school? So I think like, I just would like that to be more on the forefront for people in general in the conversation, even if it's like one line of a story, because it does matter. And if it's like centered in the conversation, it becomes more normalized to people as important to what they're thinking about for themselves. So I'm biased, but that's true in the things that I want to see. I'd assume it's sort of similar with disparity conversations, because if they're more central to the things we're talking about, it becomes more normalized to what we're talking about. And I think we just don't do a good job of like normalizing things in conversation. Instead, we make them have to be side conversations, and that sort of makes them have to be, you know, unique as opposed to commonplace. And we don't do a good job with that. But I think some people are ready for conversations like your book, Emma, and we've had that conversation where I think it can be hard to read your story, those stories for some people, and some people might not be 100% ready for that. But I think the people who didn't have the exposure to those kind of stories and those experiences, they can learn so much from not having been able to be exposed to those kind of stories and those kind of experiences, because like they weren't allowed in the hospital, right? And I think that you have this like such a unique perspective and lens that they weren't allowed to have. And I think maybe not every healthcare worker can open that book today, but maybe they can in a few months or weeks or years, I don't know. But I think it's sort of a time frame thing for people.
So I see Emily has a question too, but I'll just take a quick, quick answer to the part of the question, Emma, which is that I think one of the open questions for me, in reading the book and kind of watching the news and keeping track of everything that was going on in the past year, I am really concerned about not complete, but the deep distrust in science and public health guidance that seems to be evinced by a growing part of the American population. And I don't think there are easy answers here. I mean, I think sometimes with news stories, you sort of get the quickie analysis of like, here's, the people who think in this way politically, and here's how they respond, or people who don't believe in vaccines, and here's how they respond. But I think there's sort of a kind of a deeper and more fundamental shift happening in terms of how people think about and their trust in various institutions, including medicine and the government and science, that was evident with the response to the coronavirus, but is also showing up in discussions around climate change. And so I think that's to me one of the kind of, it's not a peripheral question. It's not directly about sort of how providers responded to the pandemic, but I think it sort of opened up that question for me in a really powerful way. And I think it's something we don't have a good handle on, and we really need to.
Thank you so much to all of you. Those were such powerful answers. And I'm glad we have this recorded, because I feel like I want to re-listen to all of that and to take it in. And Emily, I see you are raising your hand. So I wanted to give you a chance if you had a question.
I definitely don't want to cut off any conversation, but I was just, and I think that it's interesting because I think sociologists think alike here, because what I was seeing as one of the big unaddressed issues was exactly this kind of incredible assault upon science and scientific knowledge, at the same time as scientists and medical professionals in particular put their lives at risk to save these people that were questioning them. So it was very tragic. I think it was very tragic what happened that way. And I was wondering if any of these doctors or any of the people that you interacted with, Emma, have the experiences where, and I know this happens quite a lot, where they're treating patients who don't believe in COVID. And how do you manage that how do you feel empathy for someone who's sort of rejecting your professional knowledge and attempts to help them? So I was wondering if the panel or Emma had any insights about that.
Linda, do you want to jump in there? Or otherwise I can go after.
Yeah, I mean, I just briefly, I don't think when I was taking care of patients, I don't think I felt that. I think I felt that much more on a sort of general population level. When I was, working in the hospital and coming home and, donning and doffing and, like laundry constantly and everything that, we all had to go through. And then typically my husband and I would take a walk in the evening just to like be outside and, in the air and, with masks and the whole thing, and people who would be walking around without masks on and feeling literally like, and this was sort of really when things were surging here in the Northeast, and feeling like real anger, like, you know what? Don't expect me, if you get sick, don't expect me to take care of you. There was that sort of like, everybody needs to do their part. And it's not fair if you don't believe in this, or you don't believe in masks or distancing, or most recently in vaccination. I mean, the problem is that you impact on other people, whether it's that you're going to get somebody else sick, or you're going to show up, in my hospital, and I'm going to be taking care of you. And so I think that was a little bit more of my experience of wanting everyone to realize that this was not, I agree and I believe in free choice and people can make their own decisions. But in this case, a lot of this impacted everybody. And so I think that's really challenging, because I found that it made me angry to feel like people were making decisions that put others at risk, and then also potentially put me in risk if I was, at risk if I was going to be the one taking care of them in the hospital.
I live in Missouri, so I mean, I can talk a little bit about this. I mean, so I obviously don't necessarily have this from a personal perspective, but I've seen a lot of patients for this particular problem, because it makes them actually, it's a really big struggle. So over July 4th last year, there were a lot of pictures of people going to Lake of the Ozarks. And there were just like huge, just masses of people in the lakes, right? And people really struggle. I mean, like we're just like, I don't want to take care of those people. Like I can, like, how many things do we have to put on the news that like we can't? I mean, our whole hospital's gonna be full of these people that are just like in the lakes, like and people were really struggling with like this pull to do their job, and the idea that nobody was listening to them. And also, like, if they walked around in public in scrubs, they went from being really well respected to really poorly treated. And it was like a very different thing very quickly. Like in March and April, treated really well, to like once there were those like comments sort of on the news about like forging numbers and sort of things like that, it became like where they were treated pretty poorly, and like, was coronavirus real, and like all this stuff, they were treated poorly, and it became really hard. They wanted to change before they would go outside, and they didn't want to like tell people they were doctors, and it was really hard. And then like people would come into the ER, and obviously they had to do their job, but it was like people were quitting, like nurses were quitting, and they didn't want to have to like manage all of these different levels of things on their own. And it was a really like moral struggle, because obviously they do their job. We've always done our jobs. It's our job to do our jobs. Like we take care of people with Nazi tattoos, right? Like it's our job. But it's really hard when it's just like person after person after person, and you're burnt out and sad, and you can't even save them, and you're trying, and it just was so much on them on top of it. I think that it was like this like push over the limit, that I think I actually got a lot more people coming into clinic once that started, because I think it was like they had enough. Like it was like, I'm burnt out, I'm struggling, and now on top of it, I'm hated. Like I can't. And so I actually think that was a big push over for a lot of people that come see me, to be honest.
That's all really fascinating, and definitely lines up with the doctors I followed for the book. And something that stuck with me, that one of them said, there's a young man who was gay and who was really interested in sexual health, and he told me kind of a couple of times that he felt like the most careful people he knew throughout those, like while he was working in the hospital, he said he felt like the queer community in his life understood it, because they had just, so many of them had either grown up like with stories or memories of the AIDS crisis, and they understood like really viscerally what it meant for one person to really bear to bear that responsibility for the health of their community, and to know that you could be a risk to yourself and to others. And so he felt like, both as a gay man and in a queer community, he had kind of innately always felt that sense of people's health being interdependent and everyone being vulnerable to one another. And so he felt, I think, both more acutely the kind of trauma of seeing others neglect that or kind of shrug it off, and also felt like his queer community supported him in that particularly. And I want to say, I know we're almost at the top of the hour, and If anyone had a last question that they wanted to jump in the chat with, we can definitely do that. Otherwise, sorry to have run out of time a little bit on the Q&A, but I really loved getting to be in conversation with all of these brilliant people, and so grateful to Jesse and Lynn and Renee for making time for this, and to the wonderful Fox Fellowship program for putting this together.
Thanks so much. This was great.
Oh, thank you so much, Emma, for this wonderful book, and thank you to all the panelists. Sort of really fascinating and incredibly informative conversation. I think I learned quite a lot.